Welcome. As you enter, you can please let us know who you are, what state you're from, and the injury topic that you're working on in the chat. So welcome to our first State Technical Assistance webinar of 2022. The Children's Safety Network is funded by HRSA's Maternal and Child Health Bureau. The Children's Safety Network is HRSA's primary vehicle for training and technical assistance on child safety topics. And all of the information and content should not be construed as the official position or policy of the U.S. government. Please, as you're joining, please make sure that you are muting yourselves so that we can cut back on background noise. So, as you've noticed, this is the first time that we're using Ring Central for our State Technical Assistance webinar. So for those of you who may be unfamiliar with our platform, we'd like to point out a few controls to help you find your way. Along the bottom of your screen, you should see a microphone, a video camera, and some other controls about participants and chatting. So we would love for you to go ahead and mute yourselves if you're not already muted. If you'd like to come on video, as I see Jeff Hill has joined us on video, you can certainly start your video and wave hello to us. And then you can also open up your chat and see who else is in the room with us today. So we would love for you all to rename yourselves to your state abbreviation and name so that we have a better idea of who's with us today. And of course, our general tech tips. If you're not speaking, please go ahead and mute yourselves so that we can cut back on the background noise and to give our full attention to the presenters. So we will be posting a recording of this webinar on our site within the next 2 weeks. So we would love for you to be able to access that as well and share it with your colleagues. So without further ado, I'd like to share who our presenters are today. So I'm Maria Cotratus. I'm one of the Child Safety Learning Collaborative co-managers at the Children's Safety Network at the Education Development Center. Our first presenter will be Abby Collier, who is the director of the National Center for Fatality Review and Prevention. She is also a member of the Children's Safety Now Alliance, which is comprised of federal agencies, national organizations, state health departments, and hospital systems to promote child safety in the U.S. Abby will be speaking with us today about the National Center's Child Dash and Fatality Review. After Abby, we'll hear from 3 state examples of child fatality reviews from members of the Child Safety Learning Collaborative. We'll hear an example from sudden unexpected infant death prevention from Christina Phillips at the Pennsylvania Department of Health. Our next presenter will be Janice Bright from the Kentucky Department of Health, where she serves as the manager of the Child and Family Health Improvement Branch. And our final presenter is Brittany Willis, who is the Suicide Prevention Coordinator from the Tennessee Department of Health. So without further ado, I would love to hand this over to Abby.
Thank you so much, Maria. It is great to be here with all of you and see some familiar faces and meet new friends. You can advance to the next slide, please. I want to point out that much like Children's Safety Network, our key funder is the Health Resources and Services Administration, and while we could not do the work we do without them, the information that I'm going to share is the opinion of me, the author, not the federal government. Next slide, please. So today I'm going to talk a little bit about what Child Death Review and FEMR are, what our case reporting system is. I want to share a data visualization tool available, and then lastly talk about some opportunities for collaboration. Please feel free to toss your questions out there, and we will answer them at the end of all 3 presentations. Next slide, please. So to help me get an understanding of who is in the room, could you please answer the question that popped up around your familiarity with Child Death Review so that I can make sure that I'm not boring you with information you may already know. All right. I think we can go ahead and close the poll. Thank you, Kate. So most people are familiar with Child Death Review and either participate in it or know the process, which is great. We're going to take one more of these polls. Next slide, thank you, about femur. So same question, but thinking about femur, fetal and infant mortality review. All right, we can go ahead and close that process. All right, so it seems like as a whole, we're pretty familiar with Child Death Review, less familiar with femur. So thank you, that's really helpful for me as I shape our conversations. I see a question in the chat about where do SUID deaths fall? They actually can fall into both, Jeff, and I'll talk about that in a second. So go to the next slide, please. So at the National Center, we are federally funded to support all aspects of fatality review. That's everything from how to review a case to how to write recommendations and build partnership. In addition to our programmatic work, we support the National Fatality Review case reporting system, which I'll talk about a little bit later. If you haven't visited our website, I would encourage you to do so. There's a lot of really great resources on there, and some specific to how to navigate fatality review during the COVID-19 pandemic. Thank you, Kate. Next slide, please. Although today we're really talking about state and local child death review and fetal and infant mortality review, we always like to point out that for most states and even some larger communities, you're really talking about a web of reviews. And so be really intentional about how you're thinking of them, how you're connecting them, and how you're leveraging resources and lessons learned. So I would encourage you to think about if you have these review processes in your state or community, and if you do, how you're connecting to them. Next slide, please. So I'm going to kind of, next slide. I am going to skip over a little bit about what child death review is, just since everybody was pretty familiar with it, and I'll spend a little more time in femur. But in a nutshell, child death review seeks to do 5 things, which is improve the identification of deaths, support improved agency communications at all levels, improve agency collaboration around responding to fatal events, support the writing of recommendations, and then advocate for change. The whole reason we do this work is to help communities celebrate more birthdays. Next slide, please. When we think about the work we're doing, it's all focused on 2 key principles. The first is that it's multidisciplinary, that you have a broad but manageable group of partners who come together to understand the death, and that you stay focused on prevention. At the National Center, we're sort of very firm in our goals that these 2 essential elements must be present in fatality review, but we're very flexible in the methods and how you arrive there, recognizing every state and community is a little bit different. Next slide, please. Child death review has been around for decades. It started with its roots in understanding child abuse and neglect, and has since broadened to a broad public health framework. Next slide, please. In a very simplified way, this is what the child death review process looks like. I recognize that in each of your states it probably looks different than this, but this is meant to be a distilled down version. We start with case selection, move to case review, We do our data entry, and then we take action. Next slide, please. When we think about FEMR, FEMR is a similar process as child death review in that the goals are the same. More birthdays, healthy, safe communities. They get there in a little bit of a different process. FEMR focuses on fetal deaths starting usually around 20 weeks gestation until the first birthday. FEMR teams collect data in an anonymous, de-identified way, and they incorporate a family interview into their review process. So data gathering is what kind of starts the FEMR process, and it ends with a review meeting and prevention work, whereas it's a little bit different process in child death review. Both FEMR and CDR are incredibly valuable processes to a community, but there can be a little bit of overlap around certain deaths, particularly sudden and unexplained infant deaths. Some communities send them, maybe just to FEMR. Some might send them just to child death review. Others review them twice or sort of negotiate more of a gray area. You can go to the next slide, please. Although child death review is in all 50 states, the District of Columbia, the Virgin Islands, and within a number of tribes, FEMR exists in 28 states and there's 161 FEMR programs. So some states have a comprehensive network of FEMR teams that cover all of their communities. Other states may have one FEMR team. Next slide. FEMR tends to exist at the local level, whereas child death review has a pretty even split between local child death review and state child death review. FEMR is typically at a city or county level. That being said, there are states, 18 I believe, that have state FEMR coordinators, and I saw a few of them on the webinar with us today. So here is what a FEMR process looks like. They do case selection, and then there's sort of like a parallel data gathering process. In an ideal world, you have one person do records abstraction, and then you have another person do a family interview. That's typically with a childbearing parent, but it can be with a partner or a grandparent, whomever. The goal with this sort of twofold data collection process is to get not only the information from the records and the professionals, but also the family's perspective on what it felt like to navigate the healthcare system or the other systems at play. A de-identified case summary is then created and distributed to the team. There's a case review team meeting that happens, and that's professionals who come together really to put the pieces of the puzzle together and talk about what sort of best practice within their respective organization. So they don't know necessarily that they're talking about a patient that was seen in their healthcare system, so they're not responding to how they treated this childbearing person who was experiencing diabetes. They're sharing just sort of a general how they handle those types of cases. The case review team takes their findings and discussion and hands it off to a second team, which is called a community action team, or CAT. A CAT team is meant to do exactly what its name says, which is take those recommendations and put them into action. The two-tier review and action process in FEMR is intentional. The folks you want around the table for the case review might be very different than the folks you want around the table from a prevention standpoint. And so the need to have those two teams varies community to community. Much like in child death review, I've shared this very distilled down process, but it looks different in every place, but these are generally the steps that they go through. Next slide, please. I'm going to talk now about the National Fatality Review Case Reporting System, which is our data system. And the goal of the case reporting system is to provide fatality review teams with a place to collect, analyze, and report comprehensive data that is used in the fatality review process. Our data system collects everything from demographics about the fetal, infant, or child to family information, information about the death-causing event. We collect things like life stressors, so if the family experienced food insecurity or poverty, if bullying was a problem maybe for an older child, etc. We also collect the impact of the Fatality Review meeting on the community, and if there were any factors that impacted the community's ability to conduct their review. Next slide, please. The case reporting system is incredibly comprehensive. We have about 2,200 users for child death review, 280 for femur. As you can see, we sort of split either side of 3,000 variables, and we have 250,000 cases in the case reporting system. So it's a big, big data set, and we know it's a big ask of local and state fatality review programs, but it is a unique set of data, and I'll show you what we can learn from it shortly. Next slide. We have pretty comprehensive use of the case reporting system for child death review. It's used in 47 states, and it's used in 19 for femur. It's important to point out that the case reporting system has been around for child death review since 2009, but has only been around for femur since 2018. So it's much newer on the femur side, so we're still building momentum. The case reporting system has very few required variables, and there's the ability to add custom questions. So we have tried to strike the balance of a standard tool, but also build in some nimbleness for people to ask and include what they need to for their own programmatic needs. Next slide, please. We're going to transition now into some of the data, and Kate's going to launch another poll for us, which is, have you used child death review or femur data in your Title V work? All right, Kate, I think you can probably go ahead and close it. So it's great, you know, from our perspective at the National Center to see so many of you connected to fatality review data. It is flawed in some big ways, but it's also, you know, like I said, a really unique data set. You can go to the next slide, please. I want to talk now about Child Dash, which are new data visualizations that the National Center created and launched last year, that really focus on how fatality review teams can use their data. Next slide, please. There are two sets of dashboards, which I'll show you. The data are intended to inform prevention and be available in kind of an easy to use, easy to share format. It won't answer every question you have, but it will be helpful. Next slide, please. This is what the dashboard looks like, and I'm actually going to pop into it, so feel free to go to the next slide, Maria. And I just want to point out one thing, is that there are two sets of dashboards. The national dashboards, which are blue, are based on how each state has identified that we can use their data. And there's about a 24-month delay. We've created dashboards for each state. Those state dashboards have a 6 to 9 month delay in data and provide more opportunity to see numbers versus percents because of how the data use agreements are set up. So I am going to share my screen, and all right, earlier I was like, oh, it's working great. There we go. So here is what you see when you go into Child Dash, and I should have included a poll on this and I didn't think of it. So if anyone has been in Child Dash, feel free to toss it in the chat. We'd love to hear your feedback. But this is what Child Dash looks like. Each page is set up the same in that the left navigation is information about the manner. The right are some really basic demographics. And then the middle is the unique story that we can learn from Fatality Review. Each page is set up the same. And so I'm going to go into sleep related just because I know that's a topic of interest for many of the states on the call today. So here is what a typical page looks like. You'll see I have a little date slider up here. I can kind of slide around. The date that the data was last refreshed was actually a year ago today. And then I can really start clicking. So I'll give you just one example, and then we can talk about how to, build some collaboration. In this sleep-related dashboard, we can look at a number of risk factors. So were they room sharing, which can be protective? Were they surface sharing? We know that's a risk. What about objects or smoke exposure? So I'm going to say that I'm interested in cases where the infant was surface sharing with a person or pet, although pets are like this tiny proportion. If you look here at incident sleep place, you'll see that adult bed accounts for the most of those. But let's say I want to add this layer that they weren't exposed to smoke in utero. So we see things shift a little bit, nothing too terribly noticeable. So I'm going to take those off just by clicking them again. And then I'm going to come over here and say, you know what, I'm really interested in these little tiny babies because we know that's sort of where the burden of sleep-related deaths are. You can see I'm drawing a box because I want to select just these two options and my data moves around. Like I said, this is not intended to answer every question that you may have, but it is intended to inform some prevention work. I also want to point out that you'll notice that missing is included on these variables. As I said, child death review data are flawed in a number of ways, and high rates of missing and unknown are one of the ways that the data are challenged. So it's very important to our staff to include missing and unknown for the integrity of the data, because sometimes it's 50%. We have a few visualizations where it's 70%. So we wanted you to be able to see that. But we also wanted you to have the ability to say, okay, I know that smoke exposure is missing in 50% of cases. I got it. But what about the 50% that we do know about? Can I look at those data? And so that's where the ability to select more than one variable came from, so that we can acknowledge that missing, but that you can still, if you're like me and you're not a data person and you maybe, I need things as simple as possible. I often tell our staff to use smaller words. I need to be able to see it without that missing to understand it as well. So we are really excited about Child Dash. We think there's great utility for it. We're excited to share it with all of you. The national dashboard, which is what I'm sharing, is available. We're happy to talk with you about how you could use it, what it might look like. As I said, we do have state-level dashboards that each state has been given access to. There's typically their state child death review coordinator. And we're happy to make some connection there to see how we can get you access to your state-specific data as well. Maria, do you want to take it back from me and pop the slides back up?
Sure, I'll do that now.
So I actually think I went a little bit long, and I apologize. But when we come back to questions at the end, I'd love to talk about what your thoughts are on opportunities to build collaboration around this topic. So
you can take a few more minutes, Abby.
Oh, okay. So like I said, we really built this with the idea that it could be used how we're using it today, that you could share it. Well, we envisioned in person, but you know, now we're doing everything virtual, but that you could share it with a group and dynamically ask it questions, and work through those sort of layered questions together. You know, the idea, you know, in our drowning dashboard of what happens to the demographics if we look at children who drown in a pool versus children who drown in open water, or with suicides to look at manner. We really wanted this to be something that was a conversation tool. So we hope that it's useful for you in that way, and that you can use it to help you with your reporting or presentations. That really is intended to be helpful. We are growing Child Dash to include a dashboard on COVID-19, which hopefully should come out at the end of the month, as well as dashboards on life stressors, which are that sort of contextual pieces like racism, food insecurity, etc. If you're not connected to your state child death review program, or you're not sure who to connect with, feel free to reach out to me. I'll put my email address in the chat. I'm happy to make some connections. So to answer the most important question about how you gain access, you can access the national dashboard by sending me an email. We'll have you sign a confidentiality form, and then we'll get you access to it. Any access to a state dashboard has to be negotiated with the state directly, and we're happy to help kind of navigate and facilitate that. So thank you so much. You can go to the next slide. I think it's just our closing slide. Thank you so much for allowing me to join you today and share our exciting resources with you. And I'm just putting my email in the chat if you would like to get, oh, there we go.
Great. Thank you so much, Abby. This was very interesting and exciting to see all of the data in an accessible place. So we had a couple of questions. One was, as you answered, about the about accessing the dashboards. We also had a question about if the Child Dash visualization reports will be made applicable to FEMUR as well. So would you be able to answer that?
Yeah, we hope to make it accessible to FEMUR. We are starting to work through what that will look like and hope to roll that out in the next year of our funding. And then do you want me to answer the other question, another question?
Yeah, that would be great.
Okay, so if you have access to the case reporting system itself, and you do the data entry, you can, Child Dash is not in there, so you don't have access to it that way, and you would still need additional permission to get to the Tableau dashboard. So if you send me an email, like I said, I'm happy to help facilitate that process.
Great. I have a question for you, Abby. As you were speaking, and then eventually you mentioned the COVID-19 pandemic, I was thinking through the process that you were mentioning for CDR, for Child Death Review, and for FEMUR, and I was wondering how the pandemic has affected those processes. Do you know of any information about that?
Yeah, so we actually modified the case reporting system about a year ago to collect data on how the pandemic has impacted fatality review. And in the cases that they're noting an impact, the most common impact is that leadership of the team has been redirected to pandemic efforts. So we're seeing a lack of access to records just because there's nobody to fulfill a records request, and then that leadership is redirected to the COVID-19 response. We've monitored the number of cases going into the case reporting system every month, and we certainly hit a huge decline in 2020 and early 2021, but our December 2021 numbers were pretty close to pre-pandemic numbers. So we're expecting a dip again as we're, navigating the Omicron variant, but hopefully it'll rise back up.
Goody, my God.
Okay. So I was also thinking about, so if you're a Title V agency and you are seeing this for the first time, how do you expect or envision Title V agencies to use a child dash to inform their work?
Yeah, it's a good question. So I would go to the performance measures that you're working on and see where there's alignment. I would also take a look at over the overall trends around how kids are dying. I think specific to Title V agencies, when the life stressors dashboard comes out, I think that will be really helpful for all of you in describing the contextual factors that families are experiencing when a child dies. And you know, if anyone on the phone has, or on the call, excuse me, has used it, I'd love to hear how you're using it to inform your Title V work.
So we've muted everyone to cut back on background noise, but if you'd like to unmute yourselves and share, that would be wonderful.
While maybe folks are thinking about it, I'll add one use that we have heard about from our child death review teams is using it to evaluate existing programming, really to look at what are the risk factors your community is experiencing around a cause of death, and how does the prevention work you're doing align with those risk factors. So again, sleep-related deaths are a great example. Do you do you put a big emphasis on crib distribution? And what does your crib or safe sleep environment access look like in the data? So really being able to look at some of those pieces together.
Great. It looks like Joanne from New Hampshire has unmuted. Hi. So hi, Joanne.
I'm not as active with our SUID case review as I have been in the past, but what we had found is just about every parent has a crib. They're just co-sleeping instead of using the crib. So providing cribs for families didn't become our process, but we tried to provide education to both parents and grandparents that co-sleeping is dangerous and that how to back is best, bear is best, you know, the kind of crib setting a child should be placed in. So most of our educational efforts go there. Over the last few years, we've found some cases where the parent was taking opioids for one reason or another, perhaps for post C-section pain or due to substance use disorder. So I suggested that we should put safe sleep materials in the methadone clinics and try to reach out that way, so people who are having children who have substance use disorder can get the message that it's best to put your baby in their own crib, especially if you are using a substance that might make you less aware of their presence and their position in your bed if you're trying to co-sleep. So I thought that was an important thing to remind people, if you're going to be intoxicated in any way, whether it's prescription or otherwise, make sure the baby's in the bed, in their crib, not co-sleeping.
Those are great examples, Joanne. I really appreciate you sharing them.
Great, thank you so much. I see Jeannie has also unmuted. Jeannie, would you like to share?
Sure. I do child death review specifically for motor vehicle. And so we have really used that, especially with our young drivers, and really looking at the risk and protective factors associated with what caused the crash, what happened maybe before the incident happened. And also we look at what time of the crash was, who was driving, how old they were, and tying that into our graduated driver's licensing education, because a lot of them are breaking the rules associated with our state laws. So trying to use that to improve our state laws, use that to educate parents, educate drivers education instructors. And so we've developed a really good cohesive program just based off of being able to kind of see the inside pieces of what kind of led up to this and the other factors that led to the ultimate crash and then the death of the child.
Thank you for sharing that. We do this work because of the prevention side of it, and so hearing all the amazing work that states and communities do is like, just fills me right up, so thank you.
Great. Well, thank you, Abby, and thank you everyone for sharing. If you have any other comments or questions for Abby, you can continue to enter them in the chat, and we'll hopefully get to them by the end of the webinar. So now we will move on to some state examples. And if you have any questions or comments, of course, please enter them in the chat, and we'll hold all of the questions for the 3 state examples till the end of the presentations. So our first example is from the Pennsylvania Department of Health, and this was submitted by Christina Phillips, who couldn't join us today. And I'm sure that there are some other folks from Pennsylvania. I see a couple of familiar names on the webinar today, so please feel free to add in any additional information. And the Pennsylvania example is about how they created data quality summaries using Power BI and their sudden unexpected infant death case registry. So our SUID prevention topic specialist, Erin Ficker from CSN, will present their example. Thanks, Erin.
Thank you. So we are really happy to have this example, but unfortunately, like Maria said, our representative or our colleague from Pennsylvania is not able to be with us. So she did share these with us to present to you. And I just wanted to let you know that I probably won't be able to answer questions. So like Maria said, if there's anyone here from Pennsylvania, we would love to hear from you if you have any information or can answer any questions about it. So what we have here is the 2020 data for SUID case registry, and you can see it's quite a lot of data, but also a small number of cases reviewed. So you'll see that data probably is evolving, and so they wanted to share with us kind of this dashboard that they use. Oh, can you advance the slide?
This is their only slide.
Oh, this is their only slide. Okay, I'm so sorry. I forgot. So it's really small and hard to read, but I do think that there is a lot of important data here. It sounds like I understand my voice is going in and out. I'm sorry about that.
I can take over, Erin.
Okay, thank you. I'm so sorry.
Okay, sorry about that. Okay, so I'll read off what Christina shared with us about this to give a better explanation of it. So using data entered into the National Center for Fatality Review and Prevention's case reporting system by local child death review teams, data quality summaries were developed based on the core variables for the SUID case registry. The summaries provide a visual representation of how well the local team is gathering and entering the most meaningful data points. The current focus is completeness, and the summaries highlight the proportion of cases reviewed and entered by each team for which each core variable was complete, incomplete, or marked as unknown on the case report form. Accordingly, areas for data quality improvement can be easily identified, and technical assistance can be targeted to those areas for each team. So this is going into what Abby was sharing with us on the Child Dash, having those like missing values in the reports. The data quality summaries are generated using a flat file, which is downloaded from the National Center's case reporting system and contains all variables for the deaths occurring between 2019 and present that were entered by local teams. The National Center's code book is continually consulted, as variable types differ by version and section of the case report form, and if incomplete, the variable's corresponding field of the data set may default to blank, 0, or another value depending on the formatting. Accordingly, the National Center's data set is imported into SAS, and where necessary, the data are transformed to allow for calculation of the proportion of cases with complete, missing, incomplete, or unknown data for each core SUID variable by team based on the number of cases entered to date for each year of death. For core variables that are comprised of multiple separating fields within the National Center data set, if, for example, for place of incident, there are separate fields for home, hospital, etc., all fields are considered, and the variable is only deemed incomplete for a case if there was no entry in any field. The resulting proportions deemed incomplete for a case if there was no, the resulting proportions presented as percentages are then displayed visually, including using an interactive report in Power BI. So that's what you're looking at on the slide. This is coming out of Power BI. Stacked bar charts illustrate the percentage of entered cases with complete, missing, incomplete, or unknown data for each core SUID variable. Missing and unknown data are considered and presented separately. Summaries are generated by team and year of death with the long-term goal of assessing change and improvement in data entry by variable and team over time. These interactive reports in Power BI can easily be updated as new case data are entered by teams. The concept of data summaries was introduced during a December webinar for local child death review teams that focused on the SUID core variables. The webinar was open to all teams, and rollout of the SUID data quality summaries started with 11 local child death review teams, and in the future will be available for all teams. The data quality summaries will be updated and provided to the local CDR team chairs quarterly. So this is really in an effort to improve the quality of the reports, improve their completeness, as mentioned earlier in the notes from Christina, and to really improve the review and work into prevention eventually. So thank you to Christina for sharing that. And now we will move on to the example from Kentucky. Jan, we would love to hear from you.
Always helps to be unmuted. And just so everybody can chuckle, Courtney is our CFR nurse, and she even gave me a mug that says you're muted. So anyway, thanks for having Kentucky on this. I really felt like as I was listening to Abby's presentation, she presented our methodology, which makes sense given we all trained under her tutelage. So if you can go to the next slide, please. So how does data drive Kentucky intervention and action? You know, we start with the beginning of the story with just identifying those cases and looking at our vital statistic death certificate data. From that data, using all those ICD codes, our epidemiologists will pull a data report every single year based upon that information alone. As we know, that is not the entire story. So what we do is look at that as, are there large, very large and broad initial trends and patterns? From that analysis of determining that, where do we focus our efforts? And so that's the question that we come to when we get to the next slide, please. We have to look at this data, and this is what would be in our report that goes to our legislators, our Chief Justice, our coroners, and any other partner we can think of. We look at it and we go, where are we at today? And we'll start with things like with SIDS. You know, if I was to put a different graphic up that also had SUID, you would see a different count of numbers. And if I could give you that 10-year vision on this, it would really look much more alarming. In 2015, we actually had 103 infant deaths related to unsafe sleep factors. Only 55 of those had that R95 coding that qualified to be part of this particular graphic. You can imagine when we saw that number rising from 50 to 60 to 80 to 103, we were already in action trying to figure out how to determine why is this occurring. So as somebody else put in the chat earlier, we started looking at what are those risk factors? Well, we didn't have a really strong review effort at that point across our state. So we really had to make considerations around that and figuring out those risk factors to say, where do we go from here? We had to make a lot of broad leaps. We had to do a lot of surveys, a lot of polls, but that data is the driver for where we wanted to take a focus. Another thought on that same topic would be motor vehicle accidents. When we started back looking at motor vehicle accidents, and this was even longer than the 2015 area, this was back before booster seats were common to this being used in the state of Kentucky. We had a lot of kids who would age out of their car seat and go straight into a seatbelt, which wasn't appropriate for height and weight. You know, we did a lot of work that drove our community efforts around promotion of use of a regular car seat, rear facing, and our boosters. What if I had a different graphic to show you from previous reports is each time we had those interventions and we had that legislative law that backed it up, we saw a decrease in child deaths. We also use our motor vehicle accident death to look at what are our teen drivers doing. You know, that's our newest drivers with the least amount of experience. We talked to folks over at our K-SPAN area. If any of y'all know Steve Sparrow, he's very good about looking at that graduated teen driving record and the data there from Kiprick to determine, do we have hot spots in our states where our motor vehicle accidents are occurring? Because we can at least start looking at this from that geographical lens of who's having what occur and whatnot. And then from there, we work using Title V funding to support our local health departments or local agencies to address prevention. Next slide, please. This past year, in our joining of the CSLC, and this will be our second year working on this topic, was specifically related to suicide deaths. If you could see the years prior to 2015 on that graphic, what you would see is that, again, our counts were single digits. You know, when I came on board in public health in 2007, this count was hovering around 5 to 9, and it was primarily children who were greater than 15 years of age. Over the course of time, we saw that number start growing and it hitting in the teens, and then it hit the 20s. Alarmingly, we also saw that same data set where that age span was going up higher up into our early 20s. We also saw children as young as the age of 10 who were being recorded as having a death from suicide. So 2 years ago, we took on this challenge in depth with our CSLC collaborative, and we started digging into what was the data sets. There's a whole lot more data out there related to attempts for suicide and ER visits for that. That is just incredibly alarming. We looked at, was there specific methodology behind those suicides? Looking at risk factors, were there ACEs? Was it poisoning? Was it use of guns in this event? You know, was it primarily in one geographic area of our state? Previously, we would see it in scattered format across the state, and all of a sudden we saw it across that Indiana-Kentucky border. That gave us pause to think what could be happening in those counties. Again, we kept saying, where do we go from here for prevention? So with our CSLC, one of the things we looked at was the gaps in care, and we started embracing that zero suicide framework to try to find a way to capture all of the data and those risk factors that were driving this rate on the big report, and figuring out how we can map in to get some better screening opportunities. From that, we're going to do some trainings. We're going to work with some different folks in the state. We have one of our very large providers of care for adolescents, the University of Kentucky, who is working to help us with this work, and we go from there. Then on homicides, we had the same kind of thing. We saw kind of a steady rise in homicide deaths. Primarily those were children, initially under the age of 4, and there was a lot of coding around shaken baby. So we used that information to start using Title V funds to build prevention planning around trainings and education around shaken baby and abusive head trauma. We started seeing more of that same kind of thing. Homicides then were broken down into as many pieces of the pie as we could get. Where were these at? Were they in rural Kentucky? Were they related to hunting? Were they accidental discharges of the gun or true homicides, trying to get to more details. If they were in our city areas, what was the defining factor around why that was occurring? What was the geographic of those homicide deaths? And as you can see, this past year, we had a lot of growth in that homicide rate. So that takes us back to the question again, what are the risk factors? Why is this happening? That's where our suicide reviews, or our death reviews rather, become really critical, because this death certificate only gives me one piece. Oh, sorry, Maria, I'll wrap up quickly. And so it's moving on to that next piece. And so I would challenge everybody, as you look at reviews and look at your data, to not stop at just the initial counts, but dig into the risk factors that could be driving those counts.
Thank you so much, Jan. It's really great to see how your work has evolved. I remember having a brief conversation with you at a TA meeting, and to see how you've evolved this work is fantastic. So thank you so much. And next we'll hear from Brittany Willis from Tennessee. So Brittany.
Thanks so much, Maria, and hey everyone, I'm so happy to be here. I'm Brittany Willis. I'm the Suicide Prevention Program Director at the Department of Health, and I'm going to be kind of giving a different perspective, because I'm going to be talking about how other programs utilize child fatality review data to improve their programs and services, and how we in Tennessee and our suicide prevention program at the Department of Health really utilizes CFR data to improve our own programs and services. You can advance, Maria. So I just wanted to give, I'm not going to spend a lot of time on this, a brief overview of what youth suicide looks like here in Tennessee. Similar to what we're seeing in a lot of other states nationally, we are seeing a rise in not only mental illness in children and youth, but also suicide. So this is a huge priority for the department here in Tennessee. You can advance, Maria. So here in Tennessee, we really utilize CFR data to help us better understand the circumstances around suicide deaths that occur in children under 18. So we examine CFR data and include it in our suicide prevention annual report. And some of that, we've heard, utilizing CFR data for risk factors, but it is a huge reason for why we access CFR data. So looking at things such as family history of suicide, life stressors noted, so things that Abby mentioned earlier, housing instability, or things such as like parents' divorce and separation, being victims of bullying or experiencing racism. And that really helps us adapt. I lead a task force team through my suicide prevention program, and it helps us identify where there are gaps in our membership of that task force team. And it also opens up opportunities for us to partner with other organizations that may touch on some of the issues that we see as risk factors in the CFR data. We also align our suicide prevention annual report recommendations to our child fatality report recommendations, and we spread the child fatality report with our disseminate the child fatality report to our suicide prevention partners. So that really increases those recommendations and who receives those recommendations. And we break those recommendations out by grouping. So we have specific recommendations for educational institutions or state and community organizations or individuals, families, and friends. So we really highlight specific prevention and intervention opportunities for individuals or organizations to participate in. You can advance, Maria. Other ways that we utilize CFR data is really to better increase that understanding. So CFR data gives us a really good picture, but really comparing that to other data sources. So data sources such as our National Violent Death Reporting System, which looks closely at violent deaths, so homicides, suicides, and unintentional or intentional firearm deaths, and really fill in those gaps around the circumstances and risk factors. And also identify specific protective factors that we can increase within our local communities to help prevent suicide here in Tennessee. We also utilize CFR data to better support and understand our suicide-related syndromic surveillance efforts. We do use Essence here in Tennessee to identify counties or regions that are seeing increased incidents of suicide-related emergency department visits. We do the surveillance weekly. And so that can really, we see specific risk factors within that surveillance and then more details within our CFR data. So it really gives us a fuller picture of what our children and youth are experiencing and how we can help and support them to really help prevent them from attempting to take their own life. And then you can advance, Maria. And that's all I have. That's my contact information.
Thank you so much, Brittany. So we'd like to open up questions for all of the state examples. And there were some questions in the chat that I'd like to point out. Sandra asked for Jan, was zip code mapping done on the homicide deaths?
So in answer to that, we have the ability in Kentucky to use zip code identifier. It usually results in too small of data sets to be as informative as we would like. We do mostly geo mapping where we put it in our regional districts to try to determine that more from that standpoint.
Great, and there was another question about what sentinel factors occurred between 2017 to 2018 that contributed to the decline in homicides.
So unfortunately in Kentucky, during 2017 and 2018 calendar years, we were really in a very large effort to develop child death reviews across our state. We had truly about 6 teams that met for their single counties out of 120 counties who did that in-depth dive. We're now at 106 teams, so we don't have that information to know that.
Okay, thank you. There was a question actually from your teammate, Dr. Christina Howard from Kentucky, asked that they would like to hear more about states that are doing psychological autopsies. Are there any states here that do those? And this is open to everyone in the audience, actually. So feel free to unmute yourself and share. All right, while you're thinking about that, I have a question for all of you. Now that you've, for both Brittany and Jan, now that you've seen the child's dash that Abby shared, how do you envision using this information to inform your child safety and suicide prevention work specifically?
Well, when we looked at it, when that announcement came out from Abby, I have to say, my entire CFR team and I were kind of hooting and hollering with excitement. That gave us visualization of our data in an entirely new way. Now we, at this point, we're only using the system for our SUID data. So we are retroactively going to try to get 3 years in so we can see that impact on those different levels. So we're really excited. I honestly think having that will lead to, when we get opportunities like today where you do short presentations, we'll be able to present it to our coroners and all kinds of people and really get better buy-in for doing that in-depth review.
For me, and to give some background, my suicide prevention program is actually housed in the injury prevention detection section, which is where the state child Fatality Review program is also housed in Tennessee. So we have a really strong relationship with that program. I really thought that the dashboard visualization was really cool. And so I can see, you know, using that data more frequently to really analyze and cross map. Before, we were really having to wait a long time for CFR data, like a year. So this really helps, for me, really increase our understanding of suicide deaths in more real times, or suicide attempts in more real time.
Great, thank you both for sharing. And we do see a response actually from Courtney, who is in Indiana, about the psychological autopsies. And Courtney said, we are trying to push them for our suicide cases, but they're not super popular yet. Courtney shared her contact information for you to reach out to connect for the suicide overdose review coordinator. Wonderful. So we really appreciate all of your time. Thank you to Abby, Christina, Jan, and Brittany for sharing their experiences with child fatality review and how we can use this data to inform our child safety work. In the interest of continuous quality improvement, we would love for you to give us some feedback through our brief evaluation that Kate just entered in the chat. So you can click on that SurveyMonkey link. And as I mentioned earlier, we will post the recording of this webinar to our website, childrensafetynetwork.org. I'll put it on the screen within the next 2 weeks. And we truly appreciate you spending time with us today and hope that you have enjoyed learning with us. Thank you, and please stay safe. Take care, everyone.